to all chairpersons, seniors and my colleagues. Today I'm going to present myself, Dr. Neha Modani, second year junior resident from Pune. Title of my topic is Retrobulbar injection of liposomal amphotericin B in rhinoorbital mucormycosis, a gleam of hope. As we all know, black fungus is misnomer used for the mucormycosis. This is the one of the emerging angioinvasive infection caused by ubiquitous filamentous fungi of order mucorales of zygomycetes. Most common reported case is of the rhinoorbital cerebral mucormycosis. The most common mode of transfer is by the inhalational route. Angioinvasive fungal infection manifests in four forms, that is rhinoorbital cerebral, pulmonary, gastrointestinal and cutaneous. Overall mortality in rhinoorbital cerebral is about 30 to 70%. This pathogenesis behind mucormycosis, that is inhaled spore get trapped into paranasal sinuses where they block the replication of macrophages leading to fungal proliferation. It causes necrosis of the involved tissue, causing involvement of the orbit and cerebral. Most common risk factor we have seen is the diabetes mellitus, followed by the immunocompromised conditions along with the iron overload. Also the irrational use of the corticosteroids, intubation, mechanical ventilation, O2 therapy has shown rise in the cases. Patient present with symptoms like headache, stuffiness of nose, facial pain, diplopia, diminution of vision, along with the clinical features, that is proptosis, lid edema, ptosis, clinical extraocular movement restriction. For these patients, a systemic antifungal, topical antifungal as well as antibiotics are used. Surgical debridement, FES surgery along and or orbital exenteration along with treating the underlying predisposing condition like diabetes mellitus. Depending upon the history, clinical signs, symptoms, MRI and CT scan reports, we can go for surgical intervention, that is exenteration, after calculating the exenteration score. If score is more than 19, we will plan for the surgery. This is the exenteration score, which is depend upon signs, symptoms, fundus finding and imaging. Aim is to study the role of retrobulbar injection of liposomal amphotericin B in the patients with mucormycosis, that is rhinoorbital. The objective is to assess the clinical response and the safety of the transcutaneous retrobulbar amphotericin B to assess the outcome of the TRAMP for rhinoorbital mucormycosis patient post-COVID as an adjuvant to the standard systemic antifungal therapy. It is a prospective interventional study carried out at tertiary healthcare center over a period of 10 months duration during second wave of COVID. Patient having signs, symptoms, history suggestive of mucormycosis, the patient proven positive for the fungal biopsy were included in this study, and patient negative for fungal biopsy, patient not willing for study or drug allergy were excluded. In the study, 110 patients were admitted. Among this 110 patients, 90 patients is having orbital involvement without cerebral involvement. These 90 patients were the target population for my study. After seeing the diagnosis was confirmed after seeing clinical signs, symptoms, ophthalmological examination, microscopic examination and routine lab parameters and radiological investigation, fungal culture. The patient was confirmed. These are the histopathological slides showing the invasion of the mucormycosis in the optic nerve. Second image showing the mucormycosis invasion in the artery along with the thrombus formation. Third is the microscopic image showing the broad accepted fungal hyphae consisting of the mucous species. These are the few MRI reports, axial view, orbit plus the brain, showing left eye or orbital mucormycosis, showing mucosal thickening, sinus were involved and the orbital fat strangling was seen. These are few intraoperative pictures of the exenteration. Out of 110 patients, 90 patients were shown ocular involvement without cerebral manifestation. This is how the liposomal amphotericin B was prepared, and the retrobulbar injection was given after taking a prior consent and under all aseptic precautions. The doses were 3 to 5 doses depending upon the staging and the severity. It was given daily or alternate day. While this BSL, electrolyte, HB, LFT, KFT was monitored. Supportive management by moxifloxacin was given. Among the demographic profile shows that almost 2/3 patients were male, and the ocular outcome of the ramp was 61%, or almost 2/3% got improved with the retrobulbar amphotericin B. 12.2% cases got deteriorated. We took them for exenteration. These are the few clinical images showing the improvement, how the clinically patient improved after the retrobulbar injection. This is the MRI report showing how the left eye orbital mucormycosis got improved. These are few deteriorated cases. This is age-wise incidence showing that mostly 51 to 60-year male patients were got infected. This is the risk factor bar diagram showing COVID status was more commonly seen, followed by the diabetes mellitus. The result is that among 51% patients showed improvement after 3 doses of retrobulbar amphotericin B. 15 cases showed improvement after 5 doses, while 18 cases neither improved nor deteriorated, and 11 cases got deteriorated even after giving 3 doses. So these patients were exempted. Hence, conclusion is that mucormycosis is treated with a multi-dispensary approaches. Early suspension, timely diagnosis of mucormycosis at rhinoorbital stage warrant early salvage of life as well as the visual function. The patients of mucormycosis without cerebral involvement can benefit a liposomal amphotericin B by reducing the spread of disease, conserve vision, control ocular symptoms, and spare the glow. Thank you.
Thank you, Dr. Neha, for the excellent presentation. Do you have any questions for her?
Yes. What was your type of study?
It is one prospective interventional study.
And the ethical clearance you were taken for that?
Yes.
Because see, for prospective study, you need a very rigorous ethical clearance.
Yes.
You have not mentioned that one. Yeah.
What I understand is you had 90 patients who were included in the study. But what I did not understand is why did every patient get transcutaneous amphotericin B? Because the way we plan is if you have localized disease or retroorbital disease, but not diffuse disease, those are the patients who are selected for transcutaneous injection. The others, the ones with diffuse disease, would go for an exentration upfront. So, how many of those your patients were diffuse and how many were localized?
So almost all patients were having orbital involvement.
Yeah, all of them had orbital involvement, otherwise you wouldn't have given the injection. But how many of those patients were diffuse and how many were localized? That would explain why your results show 2/3 patients improving and 1/3 who did not improve.
It was localized.
All of them were localized. But
we
if you can find that data, that would make the study very interesting. Okay.
Thank you, Dr. Neha. Do you have any questions for her? Thank you, Dr.